growth, bone development, bone growth of the orofacial skeleton, of the orofacial and the facial skeleton and the dental structures. Tooth movement is very important, for example, in adduction, as I mentioned you, but this adduction tooth movement is not part of our lecture today, but we are talking about the orthodontical tooth movement, and when you apply outer forces to the tooth surface, you can initiate tooth movement, and we discussed this, and the bone growth in connection with the maxilla and mandible and the surrounding bones. And I mentioned you when you apply forces, it could be single force or complex forces with orthodontical brackets, and when you apply forces, you can move the tooth to the wanted position, to the proper position to straighten the dental arch. So the movement of the tooth depends on the force application. When you apply the force buccally, and when you press the tooth from the buccal side, you will see that the other side, so the inner side, will be the pressure side of the periodontium, because on the other side the periodontium is pressed, and there is a blood supply change and the mechanical stress in the bone and the surrounding structure. So this will be the pressure side, the other side of the active force, the opposite side, and the side of the force application will be the tension side, where the periodontium is dilated. So when the periodontium is pressed, and you will see blocking of the vessels inside, so the blood supply is reduced, and you will see that the thinning of the periodontal membrane, periodontal membrane on the pressure side, and widening of the periodontal membrane on the tension side, and on the pressure side, the bone is resorpted. Bone resorption you will find on the pressure side with the activity of the osteoclasts. Osteoclasts are the multinuclear cells, can remove the periodontal bones around our teeth, periodontal bone. And we have two bone resorption forms. We have two forms of bone resorptions, the so-called frontal bone resorption, like this, and the so-called undermining bone resorption. The undermining resorption is occurring when you apply too heavy force to the tooth. So when the force is too heavy, this too heavy force block absolutely the blood supply, and inside the periodontium there is no blood supply, and the inner cells of the periodontium will not survive, and the osteoclast will not act on the frontal side of the lamina dura. The frontal side of the lamina dura is that side of the lamina dura, or that surface of the lamina dura, which is facing to the cementum, to the root surface. And when the force is too heavy, the osteoclasts will migrate to the pressure side, but not on the frontal side of the lamina dura. They will be active, but they will be active and they will be depositing on the bone marrow side of the lamina dura. And this will be resulted in so-called undermining resorption, because the bone marrow side, or the underside of the lamina dura, is weakened, and the result will be breaking through or fracture of the lamina dura, and sudden pain for the patient, and sudden hypermobility of the tooth. So when you apply an orthodontical appliance with too heavy forces, it will be a type of, dental mistake or type of mistreatment. And the result will be that the undermining resorption is occurring on the bone marrow side of the lamina dura, and the patient tooth will be painful and movable when the lamina dura is fractured. When the lamina dura is fractured, because it is weakened, the lamina dura is weakened from the bone marrow side. But in case of the frontal bone resorption, that side of the lamina dura is removing, which is facing to the root surface, and the result will be continuous tooth movement, and this is the good practice, good practice, because during orthodontical treatment, you would like to move the tooth continuously to the wanted area, to the optimal position, to the bad position, because in orthodontical problems we have a malposition of the tooth, malposition, and aesthetical problems, functional problems. And during orthodontical treatment, you would like to move the malposition tooth into the proper position. And during this movement, you should exert continuous tooth movement and without pain, without tooth mobility, without any discomfort of the patient. And this will be resulted when your force application is not very high. And the duration of the acting force is higher than the threshold of the force application, which is 6 hours per day. So when the patient uses the appliance, removable appliance, less than 6 hours per day, the appliance will not be effective. But when you apply mild forces for long duration per day, more than 6 hours per day, the result will be continuous forces without pain, without unwanted hypermobility. And again, the force, on the force side of the force, you will find the tension zone with osteoblastic activity, and on the other side, you will see the pressure side with osteoclastic activity and bone removal, Bone removal can be seen in pressure side and bone opposition with osteoblastic function on the tension side. You can see here an unwanted complication of orthodontical tooth movement. This is the root, and on the root surface there is a resorption side of the root. And the least clinical condition you would like to find during orthodontical treatment is root resorption. Okay, root resorption, because when the root is resorted, the final result of your orthodontical treatment will be tooth loss of the patient. Okay, tooth loss of the patient. So when the force is very strong, you can find this situation that the osteoclast will eat up the root surface, and the result will be root surface or simply root or cementum resorption, resorption. The cementum can prevent this root resorption, because the cementum is that kind of tissue, hard tissue, which withstands the resorption with high capacity. So the cementum is tissue cannot resorb it easily by osteoclasts. It is. We have. You can see here cone beam CT, so dental CT picture with root resorption. Root resorption. This is the orthodontic appliance. This wire, base, and the bracket, and you can see here this palatal side of the root is resorpted, and instead of root, the newly formed bone will be at the side of the root. So this bone is formed on the previous side of the root. And this newly formed bone occupied the position of the root, and the root is weakened and resorpted, and the final result in 10 years, for example, would be tooth loss of the patient. You know, the patient will lose this tooth because of this orthodontical treatment complication, orthodontical treatment problem. And you know, I mentioned you the light continuous force application is the optimal during orthodontical treatment. You have to apply a force to straighten the dental arch to the tooth surface, but this force should be mild or light, between 10 grams and 200 grams, between 10 and 200 grams during springs and during bracket. So orthodontical appliances, orthodontical forces should be between this limit, between 10 and 200 grams. And you can see here the consequences of the light continuous force application, and the result will be that osteoclasts will be differentiated and migrating to the site of force application, to the pressure zone, you know, to the pressure side, to the pressure zone, because the osteoclasts are not located at the site. They should differentiate and to migrate, and they are differentiating because of the force application. You know, somehow the force application will initiate the osteoclast differentiation, and this differentiated multinuclear cells will migrate to the site where the pressure is increased, so the pressure site of the tooth of the force application. And the result will be the removal of the frontal side of the lamina dura, you know, frontal surface. I mentioned you this frontal side of the lamina dura is that side which is facing simply to the root surface. So the root surface side of the lamina dura is resorted continuously resorting, and you will see continuous and tooth movement, you know, the tooth movement because of this resorption of the lamina dura. And of course, on the other side, on the tension side, new bone is forming to fill the space between the lamina dura and the tooth surface. And meanwhile, the whole periodontal ligament structure is remodeled. So during tooth movement, not just the bone, but the periodontal ligament structures, so cellular and acellular structures, especially the collagen structures, are remodeled, you know. So the collagen is first breaking down or distracted by collagenase activity. You know, we have matrix metalloproteinases which can distract, which can break down the collagen, and after a new collagen structure is forming in a new area, new space of the tooth movement phase, okay? And of course, you have to maintain the width of the alveolar process. So when you have bone resorption on the inner side and the frontal side of the lamina dura, you should have bone opposition on the bone membrane side, so outer side of the alveolar process. So I show you this. So you have here, this is the frontal side of the alveolar process. This is the alveolar process, this bony process, and this is the frontal side facing toward the tooth. This is the tooth, the cementum. And when it is resorted, so when this side is resorted, you should have bone opposition on the outer side, because the